Welcome to today's cardiac luncheon where heart devices, small and mighty. I'm Peggy Schmidt, and it's my privilege as North Kansas City Hospital and Meritas Health President to welcome you to today's presentation. The pace of cardiovascular technologies has increased rapidly over the last several years. And many of these new developments have involved a focus on really tiny, placed in a minimally invasive procedure. We are very fortunate to have Dr. Andrew Boerkircher, a board-certified cardiologist with Meritas Health Cardiology, here today to talk about these devices and the procedures performed at North Kansas City Hospital as part of our comprehensive heart care program. Dr. Boerkircher and 14 other board-certified Meritas Health Cardiologists lead an incredible team of specialized nurses, technicians, and others who ensure that you receive the highest level of heart care possible at North Kansas City Hospital and Meritas. Dr. Boerkircher earned his medical degree from the Kansas City University of Medicine and Biosciences, and then he completed his residency in cardiology at Wake Forest Baptist Medical Center and his fellowship at the University of Kentucky Medical Center. Please join me in welcoming Dr. Boerkircher.
Thank you. All right. So first of all, thank you for joining me today on this warm and balmy Kansas City day. I don't know if anybody else here is tired of the winter, but I think I've had enough snow for the year. So like she said, my name is Andrew Boerkircher. I'm the newest member of the cardiology group at North Kansas City Hospital. Being in the Northland community, I think is kind of near and dear to me. I grew up in St. Joseph, so I spent a lot of time in and around this area. North Kansas City Hospital has been extremely welcoming. This is for, it stands for cardiac resynchronization therapy, which is fancy words for there's two chambers, or it's pacing both chambers at the bottom of the heart, okay? And it can also shock you out of a bad heart rhythm. So that's kind of the Cadillac of devices, if you will, but it serves a little bit different function than these others. This is a schematic showing a typical pacemaker replacement. Most people are right-handed, so we oftentimes put them on the left side, right underneath the collarbone. They sit underneath the skin, and the wire or the lead goes down in the heart and stimulates the heart muscle. So you'll see here, this is another little video showing placement of a pacemaker. First of all, some lidocaine or numbing medicine is placed underneath the collarbone. You're given a little bit of medicine to keep you relaxed, but don't knock you out completely. A small incision about 3 finger widths is made underneath the collarbone. A wire is inserted into the vein and threaded down into the heart muscle itself. Once it's down there, most of our leads are active fixation, meaning they're screwed actually into the heart muscle with a tiny little screw actually to keep them there. Next, the lead is connected to the generator, which is the power of the battery. The generator is then placed in a small pocket created underneath your skin, and it is sutured up. That's it in a nutshell. During this entire time, you're obviously monitored for your blood pressure, heart rate, and that's that. That's essentially the idea behind a pacemaker replacement. Fairly simple, can be more complex. Obviously, the more wires or leads you have in your heart can make it more complex. It can also extend the amount of time it takes to do it. But a straightforward single wire pacemaker really doesn't usually take more than 30 minutes to do. Next, I wanted to do switch it up a little bit, talk about coronary artery disease. Okay? Cardiac stents are certainly not new, been around since the 90s, but there have been a rapid advance in the stent technology over the last 15 years. in order to talk about cardiac stents, I think it's important that we talk a little bit about coronary artery disease. Okay? So what coronary artery disease is the coronary arteries come off of the aorta, the big blood vessel, once again, that supplies the rest of the body. Here are the coronary arteries. Okay? Coronary arteries, there are three main coronary arteries. One branches into two, goes on the left side of the heart, and the other one goes to the right side, goes around the back side. Okay? That's in normal anatomy. Everyone's got a little bit different anatomy. But you'll see up here a normal coronary artery. Normally, it should be nice and smooth. There shouldn't be any lumps or bumps or anything like that, no plaque. Just below that, you'll see this artery that has significant atherosclerosis. Okay, that's coronary disease. And there are a multitude of risk factors that put you at risk of developing coronary artery disease. But once it progresses to the point that is shown here, as you can tell, it's significantly narrowing the amount of area that the blood can flow through the heart or through the vessel itself. And that's the kind of thing that could cause chest pain. Okay. When the plaque progresses to the point and it gets weakened by anything, and if we had a way to know this, we would prevent a lot of heart attacks, but we don't know when it's going to rupture. When this plaque decides it wants to rupture and exposes itself to the bloodstream sees that as a hole in the vessel. It says what's going on, and it's not right, so it tries to form a clot there. Okay? Whenever the plaque ruptures and a clot forms right there, that's a heart attack. Okay? It's effectively blocking all the blood to the heart muscle. Okay? So, this is the reason why people are taken to the cath lab. The two main indications for a cardiac stent are a heart attack. Somebody's either ruptured a plaque in there, now they've got a clot, or uncontrolled chest pain despite multiple medical therapies. Okay? You can see here, in relation to this person's finger, they're very, very small. We're talking about a few millimeters wide. Okay? They go all the way down to about 2 millimeters, all the way up to about 4.5 millimeters. Okay? So not very big at all. Okay? And they're anywhere from about 8 millimeters long to up to 36 millimeters, I think is the longest. So they're not very big devices, and they actually fit within the coronary artery to open them and help blood flow down. So, what you could expect from a coronary angiogram or a heart catheterization, okay? Essentially, what happens if your doctor decides that you need to look inside your coronary arteries, they will ask you to come to our cath lab, obviously, after not eating anything for a while. We take you back to the lab and we give you some medicine to keep you sleepy or relaxed, but we don't completely knock you out, okay? It's not general anesthesia. We want you breathing. We want you to be able to talk to us and tell us if something's hurting or bothering you, because that helps us judge what may be going on, okay? But a lot of people don't remember it because it puts you in that kind of state of la-la land where you don't know exactly what's going on, okay? Next, we give you a numbing shot, and depending on what the doctor's doing or what their planned procedure is, they'll either go through your wrist or your leg, okay? Many of the doctors now at North Kansas City, we go through the wrist a lot. The reason we do that is because there's a slightly lower risk of bleeding and things like that. But a lot of times people still go through the leg. It's a bigger vessel and it's easier to get to the heart from here. Okay. So once the side is chosen, you get a numbing shot there. We go in with this sheath and a catheter. So what a catheter is, it's just a long hollow tube. Okay. A long hollow tube that we thread either through the groin or the wrist up into the heart, and we put that in the coronary arteries, and we squirt dye in the coronary arteries to see where blood flow is going. Okay? We use X-ray to see where the blood flow goes. More importantly, where the blood flow doesn't go. Okay? What we're looking for is blockages. So one of four things can come from that. One, they're completely normal, which would be great. Two, there's minor lumps and bumps, some beginnings of some coronary disease that we can control with medicines. 3, there's blockages that can get stented, and I'll show you a little bit more what that means, but we'll discuss a little bit more about that. A stent is a metal scaffold, right, that we just saw, that props up against the blood vessel wall, so blood can flow down, pushes all that junk out of the way. Or 4, there's bad blockages that would either require multiple stents or bypass surgery. Okay? And I'm sure all of you know somebody who's had bypass surgery at some point. But that's a whole other topic for a different day, I think. So anyhow, once we're done taking the pictures, oftentimes, depending on what your risk factors are or how you presented or the reason for the test, it's up to your doctor to decide if maybe it'd be better to do stents or bypass or just medicines, okay? And oftentimes we'll stop and talk to folks and say, here's what we found, you know, what's your preference? That being said, oftentimes if we find a really bad blockage that we think is causing the problem, oftentimes they open it right then and there. Okay? And how they open that is through, where do I put this in here? This is a normal coronary angiogram. And this just kind of gives you an idea as to how this procedure works. Okay? So I'm going to replay this again. So you can see the catheter coming up from the leg there, and it's in the coronary artery, and we squirted dye down the coronary artery. Okay? And that was essentially a normal one. Okay? If a blockage is found, oftentimes they proceed with stenting of the artery. Okay? So you can see here, there's a significant blockage in the artery itself. A wire is passed down past the blockage. Next, over the wire comes a balloon and a stent that are deflated and crimps down. Okay? Once they're in the proper place at the area of blockage, the balloon is blown up, and it blows up the stent. It smashes all that plaque and that crud out of the way. The balloon is then deflated, and the wire and the balloon are pulled out, and you're left with the stent in its place. That's essentially a stent in a nutshell. It presses all the plaque out of the way so that you can get normal blood flow back down to the heart muscle itself. You know, there are multiple risks that come with doing stents, but all in all, it's a fairly low risk procedure, less than about 1% chance of anything significant happening during it. So that's basically what I had planned to discuss about coronary stents. And if you all have any questions, we'll talk about that at the end. We'll get to the end. Next, I'm going to switch modes a little bit and talk a little bit about atrial fibrillation. Okay, atrial fibrillation is the most common cardiac heart rhythm problem, and a couple risk factors put you at higher risk of that. 1 comes with age. 2 comes with being overweight. Okay. So what atrial fibrillation is an irregular heart rhythm that usually starts in the pulmonary veins. If you remember, the pulmonary veins are what bring blood back from the lungs back to the heart. Okay. So oftentimes erratic signals will start within there, and they will spread throughout the rest of the top chambers of the heart. And if you can imagine, rather than having that good, normal electrical signal going to the heart, you get a very rapid, irregular heart rhythm. So the top chambers of the heart do not squeeze efficiently and adequately. Okay? Essentially sit still, they're static. Okay? Atrial fibrillation in of itself is typically not a dangerous rhythm, but what it does is when blood sits still and is not moving efficiently, it likes to sit, likes to pool. And when blood pools, it clots. When blood clots, it puts you at risk of stroke. Okay? So one of the cornerstones of treatment of atrial fibrillation is preventing stroke. We oftentimes do this with blood thinners. And of that, that's probably a whole conversation of itself. There are a whole lot of new blood thinners. Okay? But one other option we have now in folks who can't tolerate blood thinners for one reason or another, have bleeding issues, have low blood counts, you name it, liver disease, we have a mechanical occluder device that essentially occludes this part of the heart. Okay? This part of the heart is called the left atrial appendage. It is a sac that comes off of that top left chamber of the heart. To be absolutely honest with you, we don't know what it does. We don't know why it was put there. We don't know what it's for. It's like the appendix. It's there and we're not sure why. But we do know that 90% of strokes in atrial fibrillation come from blood pooling in that area. So if you can't put you on blood thinners to prevent it, we try to get rid of the left atrial appendage. Okay. There are multiple ways of doing that. This has been done for probably 50 years in surgery. When the only option was bypass surgery, oftentimes they will cut it off, excise it, put a stitch there. Okay. So there are options that way. There are also options as far as closing it off percutaneous, so through a tube, and that's what I was going to talk to you about today. Okay, so rather than having to open you up and do a surgery, put you under anesthesia, this is another option that we now have for closing off this appendage. This is actually the WATCHMAN device. Kind of looks like an umbrella a little bit, and it actually sits right here in the left atrial appendage and essentially occludes it or blocks it so that you can't form a blood clot there. Okay. And this is a little bit of the placement of it. So the access in your right groin, usually in the vein, they go and they cross across from the left or the right to the left part of your heart. They put a tube into the left atrial appendage, that's what you're seeing right there. And then they deploy this WATCHMAN device. As you can see, it just sits right there at the mouth of the left atrial appendage and blocks it. Okay. Oftentimes you have to be on blood thinners or platelet agents for a couple months afterwards, but after about 2 or 3 months, the body naturally grows over the top of it, effectively closing off that appendage and limiting your need for anticoagulation going forward, or blood thinners going forward. So I think that was all I had about atrial fibrillation. So the WATCHMAN device, there are others on the market as well. The WATCHMAN device is the one that we do in North Kansas City. Assuming that everything goes like it should, oftentimes you can come off of blood thinners after a couple months of getting the WATCHMAN device, and you don't have to have any other blood thinners going forward. Okay. Next, I want to talk a little bit about aortic stenosis. So aortic stenosis is a fancy word for that valve where blood comes from the left ventricle out to your body, doesn't open well. Okay. As you can see here, this is a cross-section of what a normal heart valve, aortic valve, should look like. Essentially, there should be 3 leaflets. They should be mobile. They should open well, all the way open, and they should close shut tight, and they shouldn't allow any leaking. And that's what a normal aortic valve should look like. And you can see here on the right, that's not normal. And what that is a calcified aortic valve. Okay, and this once again is a disease that typically comes with maturity. It comes from repeated working on that valve, and calcium is laid down on that valve. So oftentimes it will not open as well. And I like to liken it to a rusty gate. If you can imagine, if you have a gate to your garden or something like that that doesn't want to open all the way, and then it also may not even want to shut all the way. So sometimes these calcified valves also leak a little bit, because if you can imagine a nice rubber valve that sticks together and all that, that's great. But when it gets hard and rigid and it's got these rocks in there, well, it's going to have holes and may leak a little bit, okay? And they also don't want to open as well. This is a picture of the valve that we implant at North Kansas City Hospital. This is an Edwards Sapien valve. And you can see what it is, essentially, is a cow pericardium is what they use, is the the structure around a cow's heart, they use the tissue to make a valve. Okay? It is then seated within a stent. Okay? So very much the same as we talked about with the coronary stents. This is a procedure where you essentially go up over the old valve. We place a deflated stent in there. We blow it up, and the stent stays deployed right there with the new valve inside of it. Okay? So next, I think we're going to show you kind of how this works. So you'll see here, this is what a calcified aortic valve looks like. Obviously, you can see it does not open very well. Obviously, it's not opening up fully. So the procedure is we give you some lidocaine in the vein, or I'm sorry, in the artery of your leg. We go up with a wire through one of the arteries in your leg. The wire goes up across the aortic valve, as you see here. Next, over that wire goes a balloon. So you'll see a lot of commonalities here with a lot of these procedures. A balloon goes up over it, the balloon is inflated, and it cracks open that calcified valve, okay? Makes room, breaks it open so that you have room to put a new valve in. Next, the balloon is then removed, and a sheath with the actual valve is placed up into the aorta, the big blood vessel. The device is taken over the top of the wire up into the aorta, and then once again across the aortic valve. Once it's in the proper place, the balloon is then inflated, and the stent is essentially opened with the valve on the inside. The balloon and wire are then removed, and essentially what you're left with is a functioning aortic valve. And you can see here, this is how it should look when it's all said and done. So that is a little bit about what we're currently offering with fixing your aortic valve without surgery. Okay, and we have two cardiologists, Dr. Hawa and Dr. Mitchell at North Kansas City Hospital that perform this procedure. And becoming a very popular and widespread use of technology to fix that valve, because it is a major surgery to have your valves replaced. They have to open you, put you on a bypass machine that pumps your blood for you while you're unable to, and they have to surgically replace it. That being said, it's still a surgical replacement is still a very good option for a lot of people, especially if you're at low risk of having surgical problems. The issue comes when you have a lot of other issues, a lot of other problems that make you a very bad surgical candidate. That's where this comes in. Okay, this is less invasive, obviously. There's not nearly as much downtime. The only access site is, you'll have two access sites. One's in the vein, but the other one's in the artery over here, which usually gets sutured shut when you're done. So much lower risk of problems, okay, events happening from that. A lot less downtime. People are able usually to get up and move and whatnot after that. Next, I want to talk about a few things that are up and coming, and hopefully will be at North Kansas City fairly soon. We talk about them quite frequently. I want to talk a little bit about mitral valve repair without doing surgery. So percutaneous mitral valve repair. In order to talk about that, we have to talk about mitral regurgitation. Fancy word for your mitral valve leaks. Okay? And what that is, just to remind you, is the left atrium is here, the left ventricle is here, the mitral valve sits between the two. This is the aortic valve that we just discussed, but this is the mitral valve we're talking about. In some people, their mitral valve has excess tissue. It's floppy, okay? And it wants to, rather than close and shut completely and not leak, it wants to go backwards, okay? It's just like having too much tissue, okay? And if you can imagine, that's a major problem because this all here has a lot of pressure. It's your blood pressure, okay? And if that pressure is transmitted back here to these pulmonary veins, they go directly to your lungs. So if you have a lot of leaking in the mitral valve, well, that can go back into your lungs and cause fluid and cause you to be really short of breath, okay? So, in folks with really bad mitral leaking that is due to one of these floppy valves, they may be a good candidate to fix it with a percutaneous device or a non-surgical correction method. I liken it to like a restaurant kitchen. You know that a door swings both ways in the kitchen at a restaurant or something like that. So rather than it closing and shutting, it goes all the way backwards and allows the blood to leak backwards. This is an ultrasound of the heart called an echocardiogram. This is something we commonly do to diagnose heart valve problems. As you can see here, the internet quit working. There we go. The mitral valve is actually what we're looking at right here, okay? And you can tell that thing is not shutting normally. This segment of the valve is going backwards, okay? It's not working well. And due to that, there's significant amount of leaking. This color flow here, this turbulence, all this color you're seeing here is leaking of the valve backwards into the left atrium. And that is precisely what we're trying to work on, we're trying to fix doing this procedure. This is a schematic of what the MitraClip is. So this is a device that, once again, through a catheter, we can go up from the vein, as you see here, across from the right side into the left side of the heart, where the mitral valve is, and put a clip there, okay? You imagine that thing is flopping backwards like this. We can clip it so that it won't do that, okay? And this is a short video that shows basically what the MitraClip is and how it works. You can see here, this is that mitral valve, and you can see they're trying to show all that blood flow going backwards there. The clip device is actually placed across the mitral valve, and it can grasp a hold of it, okay? But here, you see that it was still leaking, so they released it. The device was actually not deployed, it was released. They grab again, and now they stop the leak. And actually, you can place multiple of these clips at one time, so sometimes people need more than one. But you can see here, it basically is like putting a stitch in that valve to hold together and prevent it from leaking. Once you get it in a good location, and we confirm that by ultrasound, we can watch while they're doing it, it is released. And that clip stays in place right there to hold that valve together, to keep it from leaking, okay? And that is the MitraClip, or a percutaneous way of fixing a leaky mitral valve without surgery. Okay. Once again, this is really only works well with valves that are very floppy and go back the wrong way. It doesn't work so well with valves that leak for other reasons, whether that be bad calcium or that be the heart ventricle is really dilated, pulling it apart, things like that. So it takes a little bit of investigation up front to determine if this is a good valve to even undergo this procedure. But if it is, this tends to be a less invasive way of doing that. Once again, in folks who may not be a good candidate to go to a big open heart surgery. We currently are not doing this at North Kansas City, but I know we are in discussions of hopefully getting there in the near future. I know Dr. Mitral has a strong interest in this, and it may be something we can get to hopefully in the next couple of years. Next, I want to talk about mitral valve replacement. Okay, so much like we just talked about replacing the aortic valve, okay, without doing surgery. This has been showing promise in the last, I think it was first started about 5 years ago at a few centers that are doing this now, replacing the mitral valve with a prosthetic valve. Currently, the only indication to do this is in folks who previously had a bioprosthetic or a tissue valve placed in the mitral position, okay? Or someone who has had a ring placed there surgically to hold it closed or tight. And the reason that is because like we talked about with the aortic valve having all that calcium that holds the new valve in place, you have to have something that the new valve can hold on to, okay? So this is a picture. This is an ultrasound, once again, of the heart showing a tissue valve that had been previously placed in the mitral position. And then you can see here, this is the color flow. The blood is going backwards, which is not good, okay? So this is someone who potentially in the future, not currently, but could in the future be a candidate, if they're not a good candidate for surgery again, to have this replaced with a less invasive means. So this, once again, I meant to put this in here to show you kind of the anatomy or how the heart looks with one of these valves in there. This is a tissue valve in the mitral position. Remember, the aortic valve is right here. The mitral valve is here between the left atrium and the left ventricle. One of the biggest complications or difficulties with doing a percutaneous or a less invasive mitral valve is that the mitral valve sits right up here and actually shares a small amount of tissue with the aortic valve. You can imagine if you put a valve in here that obstructed that other valve, you'd be in a whole world of hurt. Yeah, that would be troublesome. So that is one of the biggest issues with doing this, and also one of the reasons why it's such a hot topic right now is because it's very challenging to do this. There are a lot of different prototypes. I think there are 4 now that are potentials upcoming to fix a mitral valve. This is just one of them. And I just wanted to kind of give you an idea, essentially, of how this looks or how this works. This, very much the same way, this company, what they do is they go up and they go from the right side over into the left side of the heart once again. They go down through the mitral valve, where the part of the device is deployed and pulled up or butted against the bottom of the mitral valve. This device actually does not use a balloon, it's actually kind of spring loaded, okay? So once they get the device in the right position, it springs open. And you can see right there, it's already starting to function, okay? The device, this is just some study things, but you can see how the device was deployed in that position and held tight right there, okay? That's kind of the hope for the future of these valves. And I think that's kind of the investigational things going forward right now is how to put one of these valves in without having a prior valve in that position or a ring in that position. So hopefully that's something that'll be up and coming in the next few years. We'll give them a few years to get it corrected. But that's some of the exciting things that we're looking at as far as fixing the mitral valve. And the last thing I want to talk about is something actually that we are currently implanting. Dr. Chapman and Dr. Mitchell, Dr. Rigdon are both implanting these devices at North Kansas City Hospital. So if you remember back to the beginning of this, we talked about pacemakers. So pacemakers are a little bit bigger deal. You have to have a device that sits underneath your skin and your chest wall, okay? You can imagine issues that come up from that are infection. Oftentimes people are on blood thinners for other reasons, so you can get bleeding around that area. You can have breakage at where the wire connects into the battery. You could have breakage of the lead as it goes down here. So in certain individuals who don't require pacing of the top chambers of their heart and only need pacing from the bottom chamber of the heart, say the heart rate's just too slow or something like that, this has now become an option. As you see, and I did not put a video on, I should have, but this device is about the size of a nickel. It's tiny, about 93% smaller than the average pacemaker. It's still got at least the insert says a 12-year battery life. And it sits right down here in the end part of your right ventricle. This device is placed once again through a tube that goes up in the vein. It goes down in the right atrium into the right ventricle. And these little tines here, you see, actually hook within they don't actually go into the muscle, but they hook within the kind of the cobweb of muscle tissue that is in the tip of your heart, okay? So it's held there tight with these tines, and it paces from this little tip here. It has a little, as you can see, the shape of the back end here so that you can grab it and pull it out if you need to in the future. But this is an exciting new opportunity or possibility within pacing that we currently have at North Kansas City for certain people who are good candidates for it. And that was all that I had for today, but I will open it up for questions if anybody has